So, Dr. Serzan, I know that you just interviewed Dr. Grievous. So, what was your biggest takeaways from what you just talked to him about and from this event that just happened?
Yeah, so I think clearly the muscle-invasive bladder space is evolving, and we've seen data from the NIAGARA study which showed that perioperative durvalumab, in addition to neoadjuvant chemotherapy prior to cystectomy, followed by 8 cycles of adjuvant durvalumab, showed an overall survival benefit, and that is the new standard of care for our patients with muscle-invasive bladder cancer. It's interesting to see what the role of ctDNA is going to play. Do all patients who have the durvalumab plus neoadjuvant chemotherapy followed by a cystectomy, do they need to continue that durvalumab, or is there an opportunity to de-escalate based on ctDNA clearance and other markers that we're seeing on pathology?
And that is an important question. We always worry about overtreatment. So let's say that this does happen, you're treating a patient with that triplet regimen, a patient gets pathologic complete response, their circulating tumor DNA is negative. Would you be continuing that durvalumab today based on what we know so far?
Based on what we know so far, I would, just because the data doesn't allow us to make that change. And obviously, a lot depends on how the patient is tolerating therapy, how they're recovering from surgery. But based on the data that we have at the moment, I do stick to the NIAGARA regimen as it was presented in the study.
Okay, but we got to be really careful, right? If there's any like immune-related adverse events, would you have a very low threshold of just holding and discontinuing immunotherapy, even if they don't hit that full, finish all those cycles of post-operative adjuvant durvalumab?
It's a great question, and these are some of the longest discussions I have with my patients. For patients where we're giving adjuvant therapy, they may be cured of their disease, and where our goal is really to target micrometastatic disease, decrease the risk of recurrence of disease. That's a very different setting than the metastatic disease setting. And so we often talk about what is the risk of long-term toxicities from immune checkpoint inhibitors, things like type 1 diabetes, bad colitis. These are real-world toxicities that we're seeing for our patients, and so we do have that risk-benefit discussion. And again, in the adjuvant setting, we're particularly sensitive to that because our hope is that these patients will be cured and live many, many years.